Hello, welcome to the National Social Anxiety Center quarterly clinical education meeting. Today we are so pleased to offer this overview of the unique features of 4 different models of CBT for treating social anxiety. We have a lot of material to cover, and so I'm going to turn it over now to our first speaker. Dr. Taylor Wilmer will present the Heimberg model. Thank you, Taylor.
Great. So hi, everybody. I'm Dr. Taylor Wilmer, and I'm going to be presenting on the Rapay-Heimberg cognitive behavioral model of social anxiety disorder. And I want to first thank the National Social Anxiety Center for having me as part of this roundtable and Dr. Conlon for organizing. I'm really excited to be talking about this. A little bit about me. I'm a licensed clinical psychologist at the Center for Anxiety and Behavioral Change. We have locations in Rockville, Maryland and McLean, Virginia. So we are a regional clinic for Montgomery County, Maryland and Northern Virginia, some areas, suburban areas outside of DC. I have no financial conflicts of interest, but do want to note that I did my graduate program under the mentorship of Dr. Heimberg, so I do have a particular attachment to this particular model. So first, to talk a little bit about the rationale for this model. This is the model as depicted in the 2010 update by Heimberg, Brozovich, and Rapay. And I'm going to show a larger version of this in the next slide that will follow through as I talk, but just so that you guys can see the original model as depicted in the paper. Rapay and Heimberg originally developed this model to explain the generation and maintenance of anxiety within a specific social situation. So rather than talking about the generation and maintenance of social anxiety more broadly, they thought it would be helpful to focus on specifically the psychological experience of a person with social anxiety in a given social situation. They made a couple of assumptions when making this model. The first, that individuals with social anxiety inherently believe that other people are critical of them or are critical in general, and that they place a high importance on being liked by other people. So this is the model that I sort of put into PowerPoint that we'll be walking through today. There are a lot of components. So I'm going to be going pretty quickly, but happy to answer questions at the end. I'll also be talking through a case example as we go. Specifically, I'll be talking about Mark, who is a 20-year-old single male sophomore at a large university with social anxiety disorder and ADHD inattentive type. And for the purposes of the case example, we'll talk about a social situation where he's unsure about how to do a project for his class, how to start. And it's one day before the project is due, and he's going to office hours to ask the professor for help. For a lot of people with high social anxiety, the anticipatory anxiety might be so much so that they would probably completely avoid going to office hours for help. But for the purposes of this example, we'll imagine that he pushed past that anticipatory anxiety and made it to office hours. And we'll be talking about what his experience might be given this model. So the model starts with the perceived audience. This is representing any person or group that could potentially observe an individual's appearance or behavior. The audience could be real or imagined. So for example, for Mark, the real audience, the person who's going to be there is going to be his professor. But he may also be imagining a potential audience of other students coming to office hours who might see him ask his question and judge him for it. And the social threat can also be direct or indirect. So he might feel like he's being directly evaluated by the professor, but that threat may also be indirect, that there might be other students in the room who are indirectly evaluating him. And so given that perceived audience, when a person with social anxiety enters a social situation, they pull up a mental representation of their self as seen by the audience. So specifically, this is a representation from the other perspective. From the observer perspective, meaning it's what they imagine themselves looking like from the viewpoint of the audience versus a field perspective, like as you see out of your own eyes. This mental image is comprised of a number of different factors. So things like the visual image of the self, how you see yourself in mirror and pictures. In the case of Mark, he's tall, he's athletic, he's pale. It can also be influenced by past social experiences. So Mark's experiences with this professor in class, also the fact that he's missed a couple of classes this semester and feels a little bit self-conscious about that. It can also be influenced by past feedback from other people in social situations. So specifically, he's asked this professor a couple of questions earlier in the semester over email and has gotten curt responses from him. And then, of course, it's influenced by internal negative self-perceptions. This is getting at the idea that that mental self-image is going to be distorted, usually in a negative way, for individuals with social anxiety. All of these factors form a baseline image that a person carries with them into these social situations. So holding this baseline image in mind, individuals with social anxiety are then preferentially allocating their attentional resources to a number of different components of the social situation. So specifically, they're directing their attention towards monitoring the external environment for social threat. So noticing what other people or audience members are doing, and also monitoring internal cues of anxiety, looking for any potential flaws or things that the audience could potentially judge them on. And at the same time, they're trying to pay attention to the social task at hand. So in Mark's case, he's monitoring the professor's response, he's noticing his own internal cues, and he's trying to get his question answered. So a number of different attentional sort of divisions happening that can create what Rapé and Heimberg refer to as a multitask paradigm that then creates this heavy cognitive burden, which can then actually impact social performance in that situation for a person with high social anxiety. So Mark is directing his attention both to external indicators of evaluation and perceived internal cues. Internal cues might include things like visual signs of anxiety. So he notices himself blushing, he notices himself trembling, he also notices that his hands are feeling really clammy, as well as proprioceptive feedback, so what his body is doing. So he might notice that he's slouching or sort of tucking his head, and then additional behaviors like fidgeting and avoiding eye contact. External cues can be things like verbal signals and nonverbal signals. So for instance, when Mark enters the professor's office, the professor says, "Hold on, give me just a minute," and then glances at the clock when he walks in. Both of these things are ambiguous or neutral social signals, but for somebody who's high in social anxiety, there's a lot of research to suggest that they're going to interpret them in a negative way. So Mark may already be having anxious thoughts like, "I'm taking up too much of his time, he's busy right now, I shouldn't be bothering him." So given those internal cues, internal and external cues, those then feed back into that mental representation of the self, and it's incorporated into that baseline image. So there's a moment to moment modification of that baseline image based on those attentional, the things that a person's paying attention to, the internal and external cues, to modify how that person is seeing themselves in the situation. That observation of themselves, that mental representation of themselves as seen by the audience, is then compared to how they expect the audience expects them to perform in that social situation. So they take that mental representation of the self, which is usually negatively biased or distorted in some way, and then compares it to how they feel like the audience is going to expect them to perform. So in this case, Mark might have some pre-existing expectations that the professor thinks, first of all, students should be able to understand the project based on the instructions that I've given. So they shouldn't have to ask any questions. But if they do come to office hours, they should be fully prepared. They should do so well in advance of the due date, and they should have succinct and thoughtful questions. And then they should turn the assignment in on time. So he's comparing these expectations of the audience to how he's seeing himself and noticing the discrepancy between those two things. And the size of that discrepancy is then going to impact how he judges the probability and the consequence of negative evaluation from the audience. Meaning he's going to be asking himself questions like, how likely is it that I'm going to be negatively evaluated? And he's going to assume very likely. And then what are the consequences? Very bad. So knowing that he has missed the mark in terms of what he thinks the professor's expecting of him, Mark is going to assume that the professor is going to evaluate him negatively, maybe think that he's a bad student, and that there are going to be negative consequences. So this professor is going to not like him and maybe give him a bad grade on this project, just for being unprepared and being at the last minute. The judgments of the likelihood and the consequences of evaluation is then going to influence the social anxiety response. And when we think about the anxious response, we think about the behavioral components, the physical components, and the cognitive components. When Rapé and Heimberg talk about the behavioral components, they focus specifically on avoidance. both big avoidance and small avoidance. So big avoidance being like complete avoidance of the situation, which would have been not going to office hours at all, or perhaps escape from the situation. So maybe Mark makes up an excuse that he has to leave and escapes. But it can also be more subtle avoidance behaviors. So things that happen in the situation that are meant to either reduce the likelihood of social interaction or reduce the likelihood of negative evaluation. So in the case of Mark, he tends to avoid eye contact and speak softly in social situations and does so with the professor during office hours. We talked already a little bit about his physiological responding, the clammy hands, the trembling, the blushing. Individuals who are high in social anxiety tend to report more visible symptoms of anxiety. They also overestimate how easily observable those symptoms are. So they observe, if I feel like I'm blushing, everybody else can see. And then they also tend to assume that others judge them negatively based on those visible symptoms. So not only can they see me blushing, but they think negatively about me because I'm blushing. And this then feeds into the cognitive symptoms of anxiety, those negative automatic thoughts that happen in a social situation. So in the case of Mark, we already talked about some assumptions he might have related to his physical symptoms, right? This professor maybe can see that I'm nervous and thinks less of me because of it. But he also might have thoughts like the professor thinks I'm lazy for being at the last minute, or he thinks I'm stupid for not understanding. He's going to give me a bad grade. I'm going to fail this project. And I'm a terrible student. I don't even deserve to be in this class. So that's a quick run through of this model, but importantly, it doesn't just stop there. So this becomes a very vicious cycle. So it could be a situation where for Mark, he's avoiding eye contact and speaking softly. And so then as a result, his professor has to ask him to repeat himself multiple times and kind of looks confused as he tries to understand the question that Mark is asking. And Mark is then going to interpret that in a negative way, right? I'm not making sense, this isn't working, and that's going to feed back into his mental representation of himself. Similarly, those physiological symptoms of anxiety are going to feed back into his perceived internal cues, which is going to feed back into the mental representation of the self. So that's a really quick run through of this model. I know it was fast, but I'm happy to answer any questions, and also as we get further into the other models to talk about how this model is distinct from some of the other ones that you'll hear about today. If you want any resources, here are a few articles on the model. So Dr. Rapay and Heimberg's original model in 1997 and the 2010 update, which is what I went through today, as well as the therapy manuals based on this model. Thank you.
Thank you so much, Taylor. That was awesome. We really appreciate it. Moving on, if there are no questions, I would like to move on to Lauren, who's going to talk with us about Stephen Hoffman's model.
Yeah, thanks. There's work being done like right outside, and so hopefully it's not too distracting. I'm sorry. So I'm having some negative self-perceptions because Taylor, you created like this very fancy PowerPoint, and I'm literally just going to show a badly copied model and talk through it. So yikes. Here we go. Share my screen here. Okay. All right. Can everyone see that, or I can make it bigger? Bigger, okay. Bigger, okay. I think I can fit it all in here. Let me see. Okay, can everyone, I think, yeah, it just barely fits. Okay. So this is the Hoffman and Otto model that we use at our clinic primarily, and this is what our group is based off of. So in listening to Taylor's presentation, there is a lot of overlap here. This one isn't quite as complex. That was really interesting. And I do love the treatments that workbook. I use that with a lot of my clients. And so it makes sense that, yeah, there's a lot of overlap. But we'll start here at the top left here, where it says high perceived social standards and poorly defined social goals. So what this is referring to is that, again, that sort of perfectionistic standards that folks with social anxiety tend to have. So something like we hear, like, well, if I go to this event, everyone has to like me, or everyone, I want everyone to really be engaged with my speech, or I want, something that is like pretty lofty, very perfectionistic in nature. And unfortunately, it's usually defined with like a or very poorly defined social goal. Like, these aren't things we can know, right? So I want someone to like me. That's not really very measurable. So they'll go into some sort of social situation with these very high standards that are basically unmeasurable. So it's sort of not setting the stage for a very successful outcome. So then that leads to, if we go down to the social apprehension, of course that leads to social apprehension. I have these super high, high goals or perfectionistic goals, and I have no idea if I'll actually be able to meet them, or if I meet them, I can't possibly know. So that's going to lead to the social anxiety or the apprehension, which then leads again to this internal focus of attention, which I know we've talked a lot about at our meetings in NSAC, that, folks with social anxiety tend to be really self-focused about, monitoring what's going on in their experience, how are they coming across, and sort of missing out on what's happening in the external environment. So that heightened self-focused attention is going to really be affecting these 4 areas here that are highlighted, these 4 boxes. So first, we've got, again, that negative self-perception, like Taylor mentioned, and like we're all aware of. There's a lot of negative self-talk about how one might be coming across, if they are, blushing, if they're stumbling over their words, I sound like an idiot, like all of that negative self-talk is going on while they're trying to interact or be in a social situation. And then again, this concept of high estimated probability and cost. So there's a very, very high likelihood that disaster will ensue. And when it does, the social cost will be, unmanageable. So if I go to this event, it is very, very likely that everyone will judge me and think I'm stupid and anxious and boring. And if that happens, I will never, ever have a friend, or no one will ever like me. So the consequences are really dire. Then there's also self-focused attention focused on this low perceived emotional control. So I really can't control like this jitteriness or how I'm feeling, or maybe I'll just start crying or shaking. And I can't really control these anxiety symptoms, and people are going to see it. People are going to notice that. And then, of course, that perceived poor social skills. So we all hear from clients all the time, I don't know how to enter a conversation. I don't know how to exit a conversation. I don't know what questions to ask. I don't know what to talk about. Just this perception of not really being equipped to actually participate socially effectively. So these are sort of the 4 categories that the Hoffman model breaks down. And when folks are really internally focused, these are the things that they're focusing on. So again, a lot of overlap in, I think, what Taylor was talking about. It's maybe just a little, it's not as detailed in the model. So here we have someone, say, at a party, they're focusing on themselves, they're focusing on all of these things. How might one get through that? Well, then we go up to the top box on the right. They're going to engage in avoidance and safety behaviors. Of course they will. So maybe they're having a few extra drinks, maybe they're playing on their phone, maybe they go to the bathroom frequently, or maybe they just leave, right? There's lots of things that we know people can do, whether, overt or covert they are. So then they might engage in some sort of safety behavior or avoidance. And then after the event is this post-event rumination. And it's so funny that folks who go through our group really identify with this term. And so months later or even years later, some of my clients will be like, yeah, and then I was engaging in post-event rumination. I'm like, you sound so fancy in terms, but they really resonate with that. And so of course, after the event, after the party, there's a lot of rumination and evaluation. And, why did I say that? I shouldn't have done this. Everyone could tell I was blushing and they must have thought I was so stupid. And, sort of that negative self-talk following social events that folks with social anxiety tend to sort of torture themselves with. So they, conclude that it was basically a failure because, again, they had this goal that was not definable and overly perfectionistic, so they didn't meet it, and they weren't a success. Which leads us back again to this sort of self-reinforcing model here now we're back to the social anxiety, social apprehension box, which just gets worse and worse and worse, right? Every time we go around the cycle, like Taylor said, it's sort of this self-reinforcing process. And so I go through this model with all of my social anxiety clients, and we'll use, an example from their life or something that they tend to struggle with. And they always find it super like validating, and they really connect with it. And they're like, this is exactly what happens. And what's nice about this is we can really intervene in most of these boxes, right? Like we can help people identify more appropriate social goals that we can measure. So maybe it's not that everyone will like me, but maybe my goal is I'm going to introduce myself to 3 people I don't know. Well, that's realistic, that's measurable, that's definable, and people can feel a sense of success or accomplishment. So in our group, we spend a lot of time on having people actually define more appropriate goals. And then, of course, with the heightened self-focused attention, you can do external focus training, you can do mindfulness, you can do cognitive work around that. You can do behavioral experiments around the high estimated probability and cost. Like, did that thing really happen? If it did, how bad was it? And then obviously avoidance and safety behaviors. We all do a lot of work on that and reducing those behaviors. And then using, whether it's diffusion or mindfulness strategies or cognitive restructuring to go after that post-event rumination piece. So when I go over the model with clients, I also sort of know, like, there's a lot of places here that we can do some work around, and we can intervene and try to break this cycle. So it can be really sort of a hopeful experience for clients to talk through this model I've found. I think those are sort of the highlights. I know I was talking quickly, but I'm sure most of these concepts are not new to you all. But if anyone has any questions, I'm happy to answer them.
We are doing great on time. Y'all are awesome. I appreciate it. So I'll give you a moment. Whenever you are ready, Jim, you can get started. Jim is going to talk with us about Christine Podesky's model.
Okay. Do I need to do something, or are you just going to pop me up on the screen? Because I can begin anytime.
Go ahead.
Okay, very good. And the screen sharing, I'm sorry, do I need to select that, or are you going to make that possible?
I believe you will select screen. At the bottom it says share screen, and that'll do it.
Okay. Hope that's going to work. I do not, unfortunately, have the PowerPoint slides, and I'm going to primarily rely upon just verbally describing and maybe give examples of the assertive defensive self, of the self model. But I will see if I can expand my screen here a bit to make this a little more legible. Does that work okay? Can you all begin to see that?
Better.
Very good.
Yes, that's better. Thank you.
Okay. Well, just to kind of step back and beginner's eyes kind of come at, okay, what really is going on in social anxiety if we conceptualize it cognitively from our capabilities there. So we have, right, exaggerated expectations, and as the other speakers are talking about, of and assumptions of being judged. Yes, first of all, that our flaws and shortcomings will be noticed is an assumption. And then that if they're noticed, there's a second level of that they will be judged in some negative way. And then third, implicit in that, in order for it to have any significance, is that it's going to be a substantive or something that has some impact for us and the relationships we may have, so that it may result in something that's persistent or major enough, such as a rejection or an ongoing prejudicial view, a negative view of the person, the individual. Am I, just to join with me for a moment, does that sound in the right direction, right? But is there something missing there, right, in that model? Is that a pretty good cognitive conceptualization, or are we missing something major? And I think the assertive defensive self comes from that, the other part, which is our ability to cope with it, right? Our ability to cope with what may come is a major factor that may be involved in a lot of the other approaches. I think it is, but it isn't necessarily the primary focus to enhance our confidence in our own ability to cope with what may come. Instead of focusing on whether or not there would be a judgment of others, or whether how significant that is even, but going to another step of looking at, are we underestimating our ability to cope? Now, are any of you familiar with the model? And I don't remember where I first heard this, but it stuck out in my mind. I've put it on some handouts that I created, but that anxiety really is primarily a result of the perceived likelihood, and to put it in kind of layman's terms, of a bad event, a social, obviously social rejection judgment. How likely is that to happen? Of course, a key example in anxiety treatment would be the likelihood of an airplane crashing, for example. There's an exaggerated view. A person walking toward the plane might be feeling 50% sure it's going to crash. They get on the plane, they're like up to 95% sure it's going to crash, right? And the likelihood of, that's a good example, I think, of that. And the awfulness of a bad event, I think, is more characteristic, but perhaps insignificant, of social anxiety. That if I give a speech and my hands are shaking, I'm sweating, my voice, I stumble over my words, I lose my place, that would be, much worse than what reality would probably say. Now, that is mitigated by, or if you would make it into a division, divided by, but it's reduced into the extent that we have a perceived ability to cope. And what I don't believe Christine has discussed the self-efficacy concept, but I found it very compelling, and I have, used it in my own teaching on this topic over the years. Bandura and even John Roeder before would talk about the sense of need and value, but then how our behavior is predicted primarily by our when we sense a need or a value to do something, such as socially engage with other people, our ability to actually do it, not whether someone else could do it, but can I do it? The self-efficacy belief. And of course, we also have perceived external resources. And in the case of therapy, we want people to remember that, hey, you can come back and I'll consult with you. I'll help you out. We'll debrief, we'll work through, we'll plan on ways to be more ready next time for an event. From any CBT approach we have a next session as a resource among other things. So I think when we, just from a theoretical viewpoint, I'm adding some of my own ideas to what the Podesky model is currently, at least what my reading and training was with that. But the concepts of learned helplessness, along with the self-efficacy, are, I think, key constructs that help us in considering putting the emphasis on one's internal capability to cope. And people are, of course, preoccupied with the external, with the internal focus on their own inability to cope, and interpreting every sign of anxiety, getting hyper-focused in that biased direction, and along with the perception that others are judging them, of course. So the assertive defense of self, Christine Podesky really articulated this. I had exposure to something quite similar to this with Manuel Smith, or Pete Smith, who's wrote When I Say No, I Feel Guilty. He was one of my first supervisors at UCLA. And we did something very similar. I had a client that came in from out of town for some intensive work. And as a graduate student, I had time to do sessions with him 4 out of 5 days that week. And it was a wonderful opportunity to move from the one-on-one practice. I think all of you are somewhat familiar, so I'll jump into this little example of hearing and facing those criticisms that he, first of all, identifying the ones that he is most afraid could happen, and then kind of bridging into the model itself here. I'll go back and kind of structure it a little better. But so we listed out what some people might think of him. And this individual happened to have a glass eye, or he had lost an eye in his childhood. And so he was sensitive to that. It wasn't even the only one, but he had a variety of things. So we listed that out and then practiced one-on-one with me, kind of facing those. And then we moved to the next step of, I used a graduate class of 12 students and then another one of 30 students that were willing to use this as an experiential exercise for them. And then a group of 120 students in undergraduate class. So I'll come back to that example, but really we went through the exposure, and basically in 1 week, it was a wonderful introduction to me to the power of this. But in 1 week, this man could stand up in front of 120 students and have a stooge somewhat planted in the audience to say, "What's wrong with your eye?" And he was able to handle it in a very confident way that even surprised me how well he did it, because that was untested. One of those amphitheater kind of classrooms, and he was down at the bottom, and here's someone, he never knew this was coming at him or where, but someone's kind of throwing out this criticism of this and criticism of that. So I took it beyond just my playing the role of the critic with him, but to actually having other people participate. And it turned out to be a very, very empowering experience. But kind of whetting your appetite with that example, it was something that sticks with me from 1983 very, very vividly. Okay. So, but Christine Podesky has really brought this to the forefront in a 1997 article in the International, newsletter. I can't remember. I have it at the end here. I'll just spin forward for a moment. International Cognitive Therapy newsletter. And I had worked with her back in 88 to 91. And so I don't even recall how and when and where, but she certainly had introduced this model to me and was developing it at that time, and then published that. And then currently, by the way, I'll mention, in case I don't get to this, the 2020 Clinician's Guide to CBT Using Mind Over Mood, the second edition, does have a section that articulates the model of working with social anxiety in general, reviews the other literature, but then she brings in the assertive defensive self model there as well. We also have, of course, an interview with Dr. Podesky that Robert Yielding did. That's an excellent interview, I believe, that which she presents more of her model. And then I have a blog that came up recently, so you're certainly welcome to look at that, covering some of the same material today. Sorry about the dizziness of moving my screen like that. Everyone awake? So here we're not focusing in assertive defense of self on the likelihood of being judged and criticized so much, for a lot of reasons. One of which is maybe they will judge you. So it doesn't matter if you're 98% sure. We all know this from treating OCD and a variety of things. It doesn't matter if you're 99.5% sure. You still can have a lot of your attention focused on, well, what if? What if that small chance is that someone would notice this? Maybe everyone else has been nice, but but this person, someone might not be. And then what am I going to do? What if I'm in front of other people? As well as, what if they're thinking that? And, how well do we cope with that by doing thought records versus something more experiential for that part of what they might be thinking of us? So, so I like to, the primary focus here is on standing up and challenging the criticisms to experience your capability to not just think about how you would mentally, cognitively respond, but actually face the very worst things you fear someone might think of you. Now, a lot of the problem that I think Christine Podesky and I also agree that is that in the variety of strategies we use in CBT to get people out in the field to do exposures, which are wonderful and essential, but we may or may not facilitate exposure to the very worst thing they fear someone would say of them or what someone would think of them. And so the beauty of the assertive defense of self is that you can actually make that happen. You can get the purity of what is their worst fear and play it out. And to the degree to which you're a good actor, you can bring in a number of dimensions: volume, proximity, intensity, facial expressions, and can do it on a hierarchy. So you can control that exposure to gradually empower that person to reach that sense of self-efficacy. And I have seen it happen after a certain number of exposures. So it really follows the model of a phobia treatments. You design the specifics and you bring that exposure in, you ask about it, debrief, then change, modify it to make it a more gradually more on a hierarchy, more of a powerful exposure. Asking them, well, so you felt pretty good about that, but what if, are there certain things that you would fear that might happen that we didn't cover in that last role play? So we go through a series of role plays, playing out the fears verbally, but then you can add other dimensions, nonverbals, facial expressions, and you can also have someone entering the room. You can bring in other participants. I've used my office manager, for example, and when I don't have someone else, and she's done a great job even of helping to recreate as many dimensions of that situation as possible. Virtual exposure through, has some advantages, but also has disadvantages. This is real life people. Of course, clients say, well, I know that this is a role play. I don't think it's going to make me anxious. Of course, that's an avoidance behavior. 9 out of 10 times, we all know. Because when we do the role play, guess what? They experience anxiety virtually 100% of the time, at least the way I do it. And I was an actor in college, so I can be just about anything they need me to be to provoke them, their anxiety. Kind of can have fun with it even. So you get to vary what's being said, how it's being said, to provide the optimal exposure to that which they fear, and then you can debrief in the moment. It's another great component of this. You don't have to allow for that post-event processing to do its damage, to do its dirty deed to the person. You send them out there on a homework assignment. Something doesn't go perfectly, or they're caught up in a speculation of what the others are thinking of them. And what they did was great. And sometimes, obviously, it works for a large percent of people. But then there are that post-event processing. We get a chance to get right in there, find out, inquire about it, without having to go out in the field with them sometimes, and provide the modifications to address that more adequately. So that's a part that I really like, and why I think there are some real advantages of using this. Now, of course, the criticism is, well, but this is too contrived, this is too controlled. We want people to not have it scripted. People need to be able to feel confident to deal with the unexpected. Scripting it's going to compromise the integrity and the, et cetera. I completely disagree. Completely disagree, and I'll tell you why. Because all you have to do is to do this for one session and then they're out in the field. It doesn't take away from facing that. It simply empowers them so that they don't go in and have this slow, laborious, partial exposure experience, negative post-event processing that kind of taints it. So you got a step and a half, 2 steps forward, but now you got to step back. You don't have to neglect the unscripted. You simply have to explain it, facilitate it, make it happen with the client.
Thank you, Jim. In the interest of time, we need to move on. Next up are Randy Weiss and Dr. Daniel Chazen, who will present David M. Clark's model.
Today, I'm going to speak to the David Clark model. I should say the cognitive aspects of the David Clark model of social anxiety. Clark posits that socially anxious individuals have developed their negative beliefs and images about themselves from some social trauma that occurred earlier in life, very often in adolescence. And so then the individual goes on to develop conditional assumptions about the world and negative beliefs about themselves. He says that there are 2 key maintenance factors for social anxiety disorder. The first is a hyper self-focus on the client's physical symptoms and negative thoughts versus being able to focus externally when they're during interaction with others. The second maintenance factor is a heavy reliance on safety behaviors. Where I think Clark differs from other theorists is how he goes about getting clients to alter their negative core beliefs. So instead of doing thought records in advance of, particularly in advance of behavioral experiments, Clark has patients identify 1 or 2 negative beliefs from the questionnaire that they work on altering using very strategically designed behavioral experiments. And he has the client make measurable predictions that can be observed and then drop some safety behaviors. So I'm now very quickly going to touch on 4 core cognitive components of the Clark model. The first one is his use of routine questionnaires pretty much in every session to guide treatment and experiment planning. And 2 of those that I like in particular are the social cognitions questionnaire, and then one I'm going to show you right here, which is the weekly summary scale. And I like this one because it gauges the client's level of avoidance and self-focus and rumination during the prior week. The next core component, a cognitive component, is the model itself, Clark's model. And let me show you what that looks like. So I think 2 distinguishing factors of the Clark model for social anxiety are, first of all, this piece on negative self-focus and image. He has a very clever way of eliciting from the client how they think they look to others. And then he links that right back to the original social trauma, so that all the elements of social anxiety disorder are very nicely tied together in a way that helps the patient connect all the dots linked to a situation that they walk through. The next third cognitive element of Clark's model is his very third session, typically in treatment, in which he does an experiential exercise with the patient to loosen their negative beliefs and self-images. And what he does is he has the therapist bring in another therapist or some other surrogate and conduct 2 conversations with, in quotes, a stranger. And in the first conversation, the patient is instructed to drop their to maintain their self-focus on themselves and do their safety behaviors. And then in the second conversation, the client is told, now I want you to get absorbed in the conversation and try and let go of your safety behaviors and see how that goes. Then this recorded session is very carefully and strategically debriefed to maximize learning. The 4th cognitive component that I want to mention today is Clark's then versus now technique, also known as discrimination training or stimulus discrimination. This is his first line intervention to address the social trauma if it has not been sufficiently loosened up heretofore in sessions and several experiments. And what Clark has the client do is identify key differences between the original trauma, the environment, the people, the patient's age, and so forth, and compare that to the environment that triggers them now. A list is made, and then the client is instructed the very next time they're triggered in a social setting to turn their extension very deliberately externally, the way they've been practicing, and note the differences in the current environment, which is the now, from the original trauma, the then. Thank you.
I'm in the least favorite position of going last, but I will try to keep this brief. So skipping the about me. For me, Clark's model is the go-to in treating with social anxiety. And so Randy's already spoken to the overall bits of the model, but I'll talk very briefly. There's a lot of basic research showing support for the model and the theoretical propositions. excellent efficacy data. It really works quite well and has been compared back to back with other alternative treatments and often does better. It's also very acceptable to patients. A brief snippet of a graph. If you look here, the gray bars on the right are all variants of Clark's treatment,
Oh,
in which it's been compared directly in efficacy trials. It does better than waitlist. It does better than placebo medication, better than interpersonal therapy, which has been supported for social anxiety, and better than SSRIs, and better than exposure therapy, which is something I'm very comfortable with and offer for OCD, for panic disorder. Here, exposure therapy is not our go-to. It shouldn't be, at least, when you see data like this. That really suggests that a more cognitive approach is warranted. So let's talk sort of about one of the most active ingredients of Clark's therapy, and that's experimentation. Randy spoke a little bit and set up this idea, but the core of the treatment throughout those 14 or more sessions, you're really going to be doing a lot, experiment after experiment. Some of the other stuff, attention training, which we've talked about in meetings before, or kind of then versus now stuff, happens, but it's regarded as supplementary. So usually there's one session on attention training, and then versus now work is an optional module for Clark. So we only get to that later if we think that things aren't resolved largely through the earlier work, which is focused on experiment. What are experiments? So experiments are carefully planned behavioral exercises designed to test the validity of specific beliefs, assumptions, appraisals, interpretations, or biases in attention. Those beliefs or ideas could be about the self, the others, and the world. So it's very cognitive from the start. We're talking about how the person, what sort of assumptions the person's making about the world and about themselves and how people are going to react to them. And we're basically starting with the proposition that some of those ideas are not particularly helpful and not fully supported. That doesn't mean they're utterly wrong, but they're not the most useful ways of guessing what's going to happen out in the world if you are who you are and how other people see you. Also, attention is one cognitive component. So there's a bit of a bias here that we start off with. Randy set this up where we do an experiment briefly at the beginning where we're saying, hey, you're probably paying a lot of attention to yourself and not paying too much attention to conversations or to the things you guys are, the things you talk about with other people or talk about when giving a presentation. So that might not be the most helpful either, that there's a bias there. So some more definition and context. Experiments, a lot of us, when we have meetings and we're talking about things, we use the words interchangeably and for good reason. Experiments and exposures, we say either one. But there are some differences. There's similarities and differences. So experiments are similar to exposures that we would do in an exposure-based therapy. Experiments in Clark's model and similar models are similar in that we're doing experiential learning. We're going to go out, we're going to try things differently and see what happens. But they're also quite different for those of us who do cognitive therapy and exposure therapy. And those differences are important to emphasize as well, so that we're not always using those two things perfectly interchangeably. In particular, I think some of the differences is that we don't really look at anxiety. We're not doing SUDS. Never collect SUDS when you're doing an experiment. Almost never, unless that's a prediction. It's irrelevant. It is not the point of success. It's not the point of failure. It's regarded as ingermane. In particular, that's because anxiety is seen as epiphenomenological. So you're anxious and you're overwhelmed by these situations because you're focusing so much on yourself. You're preparing beforehand. You think that other people are judging you, and that's what's making you anxious. Measuring your anxiousness and how it goes up and down is not important. And we're going to want to shift the focus right away. Just other couple notes. There's some other things I could explain. There's no hierarchy. You're not practicing from the hierarchy. There's no practice. Practice isn't the way we look at it. You don't do things repeatedly unless they gain you more information. So in an exposure therapy, we're going to assign people, go out, do this 3 times for homework. In Clark's model, never do that. It's not, why would you assign it a second time? If you gained enough information, you're going to do a different assignment to find something out. Also, the idea that experiments, that exposures are prolonged. They're not necessarily, experiments are not necessarily prolonged. You do it only for as long and for as many times as you need to gain the information needed. The model here is science. The naive scientist model in social psychology is sort of like an intellectual kind of predecessor for this. We're getting patients to think like scientists, to start regarding their own ideas about the world as assumptions, and then to go out and test those assumptions, generate predictions based on them, test them out, gather data, and revise your assumptions, revise your theory. So that's the model here. That's different again from exposure therapy, but that's okay. There's a progression in Clark's treatment. Typically, we start with the focus of attention and safety behavior experiment. Sometimes there's, which Randy went over already. I could always explain another kind of session. We then sometimes progress to a people are looking at me idea. So we'll assign patients to, okay, go out there and look at the ground, right? Do something funny, maybe dance around or something like that. Look up, look like a hawk. How many people are looking at you? How many do you predict beforehand? And let's see. That time you'd got only 2 people. Let's do it different. Shake, wiggle around, drop something. Let's see what happens. Oh, now you have 1 person looking at you. This is based on the idea that most people are assuming, most people with social anxiety are assuming that people are looking more than they actually are. Then we progress into experiments looking at likelihood of feared outcomes and then consequences of feared outcome. This follows Hoffman, Heimberg, everybody else. It's the same, FOA, all of those theorists. Sources of information is one area this model differs. You're going to get information from experience, but you're also going to do it. You can get it from live interactions, speeches. You can get it from role plays. You can do it from reviews of videos. So if we videotape things, which is recommended, or we audio tape things, let's play things back and see what actually happened, so we can learn and test out these ideas. You also can get it from direct feedback. So after interacting with 4 people, let's design a questionnaire that asked them how stupid you looked, how much you gritted your teeth and looked angry, how much they want to see you again, would they ever be willing to talk to you? Get right at the predictions. That's another thing that's different from a typical exposure response. You're directly testing predictions. A lot of us, when we're doing exposure therapy, we're going with this intolerance of uncertainty idea. You'll never know. Here, nope. You're going to know. There's some things you'll never know, but everything else, we're going to try to gather data on and find out what is the most likely and most well-supported theory.
Thank you again to our speakers for such a wonderful presentation. We really appreciate your time and your expertise. Our speakers will return in November to continue this discussion, and also at the same time, we will hear part 2, where Larry Cohen will present on integration of these models. Digital materials and resources provided by the speakers during this presentation will be available on the website underneath the video. We look forward to seeing you all again. Have a good week. Bye-bye.